Good evening, everyone. Welcome to Mahamana Case Discussion Series. Today we have with us Dr. Riddhi Sood. She is Assistant Professor from Kidwai Memorial Institute of Oncology, Bangalore. And ma'am is going to deliver a talk on management of minor salivary gland malignancy. Welcome, ma'am.
Hello, good evening all. Thanks, Sunena, and thank you, organizers for this opportunity. I'll just share my screen. Is my screen visible?
Yes, ma'am, it's visible.
So, topic given to me today is on minor salivary gland malignancy. So in this talk, the basic outline for my presentation would be I would be covering the basics about minor salivary glands, its anatomy and physiology. Then we will be looking at epidemiology and the histological diversity it presents with. Clinical presentation, what we get in these set of tumors, then how do we work up these patients, and what are our main treatment decisions about surgery, neck dissection, and adjuvant treatment. In the end, we will be looking at management of unresectable, recurrent, and metastatic spectrum, and we will also see the survival and prognostic factors and how to follow up these cases. So let's start with the basics. So minor salivary glands are many in number, up to 1,000, and they are dispersed all throughout the upper aerodigestive tract. And they are very small, about 5 millimeters, and they are embedded in the submucosa. They lack true capsule, and they constitute for only 10% of salivary secretions, and their constituent of secretions mainly consist of mucinous in nature, except for few glands which are von Ebner's gland, which are mainly for the serous component of the saliva. Coming to the distribution, so apart from the upper aerodigestive tract distribution, we find them in the lacrimal gland and the external auditory meatus in the nasopharynx. But most predominant constituent is seen in the oral cavity. So the second picture on the right shows purple highlighted areas which show the distribution of these minor salivary glands in the oral cavity. So we often see them in our MRI scans. So they are seen as subtly enhancing hyperintense areas when we look at T1 fat suppressed post contrast images. And one second, I'll just try to point. Is the pointer seen? Yeah.
I can see it.
So it is seen in the submucosa of the lips. It is seen in the anterior lingual aspect, in the posterior lingual aspect, in the retromolar trigone, in the posterior part of the hard palate and the soft palate. And these subtly enhancing areas on the lateral aspect of the posterior base tongue is the von Ebner gland. And we also see them in the retromolar trigone. So when we look at the basic architecture, we see that the architecture resembles that of the major glands, except for a less developed acinous system. And these are mainly mucoid acinous. Sometimes we also see serous acinous. And their excretory ductules are less developed. Based on their predominant site, we see that the excretory system can have varying degrees of development. So coming to epidemiology, So these salivary gland tumors overall constitute for less than 10% of all head and neck cancers, and among less than 2% of all head and neck cancers. And among these all salivary gland tumors, if we look at minor salivary gland tumors, these are only 10 to 15%. And what is to be noted is 80% of these tumors tend to be malignant as opposed to their counterparts in the major salivary gland, where majority, that is 80%, are benign. And if we see the annual incidence, it is less than 1 per 100 million people. And this is mainly from Western literature. As far as the risk factors for minor salivary gland carcinoma is concerned, we do not have specific risk factors for these. But for sinonasal adenocarcinomas, we know that exposure to hardwood dust is a known risk factor for development of sinonasal adenocarcinomas. Coming to subsite-wise distribution, so as their distribution is predominantly in the oral cavity, we see these minor gland tumors mainly being found in the oral cavity, that is 68%, and in the oropharynx, that is 21%, followed by rarely in the sinonasal tract, and lastly in the larynx and trachea, which is less than 3%. So they present in vast histological diversity, and what makes them complex is the evolving terminologies and classifications, which keep changing very frequently. And with the advent of immunohistochemistry and molecular diagnosis, we require them for accurate classification of these tumors. So currently what we are following is the 5th edition of the WHO classification, which came in 2022, and it described 21 entities of the malignant spectrum of salivary gland tumors. I have highlighted in brown the ones which occur in minor glands. So we have mucoepidermoid carcinoma, which can be low, intermediate, or high grade. Adenoid cystic carcinoma also can be low, intermediate, or high grade. Acinic cell carcinoma tends to be a low grade spectrum tumor. Secretory carcinoma, which is a relatively newer entity, is also described in minor glands, which is also on the low grade spectrum. About the polymorphous adenocarcinoma, so it is no longer called PLGA, which was previously because of its low grade behavior, but they found that they have variable outcomes, and now they are called as only polymorphous adenocarcinoma. And they include a subsite, which is a cribriform adenocarcinoma, or CAS-G, which is mainly found in the base tongue area and has predilection for nodal metastasis and female patients. Other uncommon ones are epithelial myoepithelial carcinomas, which are also low-grade tumors. And in the sinonasal tract, we commonly encounter adenocarcinomas. So when we see histology-specific subsite-wise distribution, we see that I told you the 3 most common ones are the mucoepidermoid, the adenoid cystic, and the polymorphous adenocarcinoma, whereas all the others are rarely found. So now for correct terminology usage, we need to subject them to molecular diagnosis. This the paraffin embedded material can be subjected to FISH or next generation sequencing to ascertain the particular molecular alteration. This is important, one, for ascertaining the correct diagnosis, and secondly, to utilize these for any targeted therapies, which are basically available in the recurrent and metastatic spectrum and not in upfront cases. So do we have any subsite-wise specificity of histology? So yes, what we see is the areas which are lined by squamous epithelium. For example, the oral cavity, the oropharynx. These tend to have mucoepidermoid carcinoma, seen as blue. So we see that they predominate in the oral cavity, whereas those areas which are lined by respiratory epithelium like sinonasal tract and larynx and trachea, they usually develop adenoid cystic carcinomas. So how do these patients present to us? Usually they present in fifth and sixth decade of life, but extreme age groups are also documented. They are more commonly found in females, and the symptoms with which they come to us depend upon which subsite is involved. So the most common presentation is a asymptomatic painless swelling, which is seen as a submucosal bulge in this picture as a at the hard palate. And this submucosal mass will be adherent to the mucosa and sometimes present as overlying ulceration. It is important to note that pain is an omnious finding, and it usually presents when the patient comes to us late due to deep submucosal extension or because of perineural invasion. When it occurs in the sinonasal cavity, patient presents with epistaxis or nasal obstruction, whereas in the oropharynx and larynx, classically they have dysphagia, dysphonia, or breathing difficulty. So sometimes we have to keep in mind other differentials. Benign mucocele can sometimes look like a low-grade neoplasm, IgG4 related disease, and other unusual but known DD is a acute necrotizing cyalometaplasia, which because of its ulceration and necrotic center usually masquerades a malignancy, and most of the time we do biopsy and then we get this diagnosis. These are self-limiting condition which self cures after if left alone. So we can also have nodal metastasis at presentation, and usually we see these nodal metastasis in patients presenting at an advanced stage or in high grade tumor, or when the primary involves oral cavity or pharyngeal subsite. And distant metastasis at presentation is rare and is found in less than 10% of patients. So how do we work up? So first and foremost in the workup is an imaging. Most often we tend to do a cross-sectional imaging because these are at inaccessible sites, unlike major glands which are easily amenable for a office-based ultrasound. So with the cross-sectional imaging, our objective is to see whether there is any likelihood of development of malignancy. We want to map the local extent, and we also want to know if there are any regional or distant metastasis. So the investigation of choice is a contrast enhanced MRI because of its soft tissue delineation and its ability to pick up perineural spread. CECT is complementary for its ability to give detail about bony involvement, and we reserve whole body PET scan for high grade histology to do a comprehensive distant workup. So in the MRI, we look at margins, and irregular and infiltrative margins indicate malignancy. And especially the T2 weighted imaging helps us in giving insight into the histology. So a high grade tumor having high histology, high cellularity will be hypointense, whereas benign tumors tend to be hyperintense. Similarly, with the help of diffusion weighted imaging and dynamic contrast imaging gives insight into what could be the probable uh, histology. So we have basically two types of spread patterns which we look on radiology. And the low-grade tumors tend to be localized where they cause pressure erosion. So whenever there is a image which shows a well circumscribed mass with a long history, we look for pressure erosion of the underlying bones. These are considered to be localized as opposed to the invasive type, in which we see that they have submucosal spread into the deeper underlying soft tissues like muscle, bone marrow, and perineural spread. So in this image, which is a T1 weighted fat suppressed post contrast image, you can see how this was a case of adenoid cystic carcinoma. It has permeative borders, and how without producing an external bulge, it is creeping all along the septum, going posteriorly into the clivus and also entering into the body of or the marrow of the clivus. So silently they keep going deeper into the deeper structures as well as perineurally. So, because of the propensity of these tumors, particularly adenoid cystic carcinoma, for perineural spread, we should be abreast at picking up these signs of perineural spread on CT as well as MRI. So basically, how it is to be read is we have two major systems which we have to see. One is the facial nerve, and one is the trigeminal uh, divisions. And based on the proximity of where the tumor is, we trace these nerves in a retrograde fashion to their foramen, and from there to their ganglion, and from there to their cisternal segments, which is classically described as different zones of PNS. And we see different sequences on the MRI to ascertain what could be direct as well as indirect signs of perineural spread. So, among the direct signs, we divide them into acute, which is the nerve enlargement or enhancement seen on T1 contrast pad suppressed imaging, obliteration of the fat pad around the nerves, and in indirect signs, especially in early stages, we look for the muscle which the nerve is supposed to supply. If it shows T1 hyperintensity and it is bulky, it is because of the edema. And in subacute setting, they tend to lose their bulk, and in the chronic setting, they tend to atrophy, which is also seen as a T2 hyperintensity. And sometimes when the patient presents late on CT scan, we see that there is gross widening of the foramen. So this is an example of adenoid cystic carcinoma which presented at the hard palate, and it has involved the greater palatine vessel, seen as widening of this foramen. And in the third image, it is seen to go posteriorly into pterygopalatine fossa. It is showing widening and also widening of the Vidian canal. So I have just summed on this slide, and this reference is also important for understanding this complex topic of perineural spread. So after imaging is done, next we want to delve into how to obtain a tissue diagnosis. So easiest would be an FNAC, which has a good sensitivity and specificity upwards of 80 to 90%. And it can correctly tell us whether it is benign or malignant. Probably it will not be able to tell us the subsite or the grade, but if we are able to make a cell block or a FNAB and IHC, it can fairly give us the insight into grade as well. But what is more important in minor salivary gland tumors, particularly, is the role of incisional biopsy. And in sinonasal tract, we do an endoscopic punch biopsy because these tumors are submucosal extension. So we have to incise the intact mucosa and go deeper into the tumor to get a good representative specimen for the pathologist, and also we get a good specimen to subject it to IHC. As far as staging is concerned, we do not have a specific staging system for minor salivary gland. We have to depend upon site-specific TNM staging, same as squamous cell carcinoma. Before delving into management, I just want to highlight what are the problems in understanding the literature about these rare tumors because of the inherent heterogeneity which they present, be it histological subtypes or be it there's so many sites in which they present. So either we have studies which combine all of them together, in which we have difficulty in generalization of the results, or sometimes we have studies who have divided them based on a particular histology or based on particular site, but they tend to have very less numbers to give us any measurable result. So, on doing a review of what homogeneous articles we have on looking at minor salivary subsite altogether, we see that they pan across a duration of some of say 20 years, 15 years, in which time there has been change in the nomenclature. Some entities have been removed, some entities have been clubbed together. So interpretation of the data in a heterogeneous and rare setup is always difficult, and hence we do not have a separate consensus statements or guidelines for this particular entity. But we have a fair estimation of how to manage these patients. So what we know is surgery is the mainstay of treatment. Approach can be decided based upon the surgeon, whether it can be open or it can be minimal access. What margins to give? So we tend to give conventional margins based on the subsite. We aim for 5 more than 5 gross microscopic margins, because a positive or a close margin reduces the survival by almost half. About what to do, whether to do frozen section or not. So it can be done in areas where we have contention about margin, or if we want to look at a margin on a perineurally invaded nerve, or we can do it on a lymph node, but it should be used wisely only if it is changing your plan of surgery intraoperatively. And reconstruction would be done as and when required based on general principles of surgery. About neck dissection. So remember, patients who are presenting with a N plus status, we do a comprehensive neck dissection. And patients who present with a N0 status, elective neck dissection, when is it warranted? So it is warranted in patients presenting with a high grade and a high stage tumor, if put simply. And what are the levels we have to address? So this is basically on general principles. For example, oral cavity 1 to 4, oropharynx 2 to 4. And certain subtypes have a higher predilection for nodal metastasis, like high-grade MEC and adenocarcinomas, where END is always advocated. So general dictum is high-stage, high-grade tumor, you do elective neck dissection. And in as a general rule, we can take that if we are using the neck for an approach for primary or reconstruction, it is better to do neck dissection. About elective nodal irradiation, these can be advocated in certain scenarios where we are taken by surprise about high grade histology in the final histopathology report. Coming to adjuvant treatment. So following surgery, when do we want to give adjuvant treatment in form of adjuvant radiotherapy? Again, simple answer is high grade, high stage tumor. Whenever we have closed margins or incomplete resection margins, we tend to give radiotherapy. And radiotherapy is also indicated in N plus or ENE positive nodes, and also whenever there is perineural invasion. And there is no known benefit of adding chemotherapy to adjuvant radiotherapy. What do we do when the patient comes to us in an unresectable stage, or when the patient is unfit to undergo surgery? These patients can be treated with a curative primary RT using IMRT, and also newly available particle therapy like carbon ion or neutron, which have better conformal radiation. It helps in a higher locoregional control. Again, we do not have a known benefit of adding chemotherapy to RT in this setting. About recurrent and metastatic, I would just touch briefly. We know that when surgery is not in picture, it is very difficult to give them any optimal control rates with any other modalities, be it radiotherapy or be it systemic therapy. When the patient is in a resectable stage and has metastatic disease, we still tend to operate these patients for the survival benefit. In terms of recurrent and metastatic setup, the discussion has to be done in a multidisciplinary setup, where we can discuss about the role of re-RT and now the new molecular markers and targeted therapies are being implicated. So this is just to summarize from the ESMO guidelines. It has a section on minor salivary gland. It summarizes the treatment what we have discussed so far. Now, when we have treated the patient, they tend to ask us what are their chances of overall survival. So we see that these patients have a good 5-year and 10-year survival of more than 70 to 80%. And what dictates these good survival is based on their age, their gender, their stage of presentation, their grade, tumor grade, whether surgery was done or not, and what was the margin status. So these are all the factors which help us in prognosticating these tumors. And beyond AJCC, we also have availability of nomograms. Lan et al. Looked at giving us nomograms for overall survival as well as disease-specific survival, which gives us all these factors, and we can give us risk estimates to our patient regarding how their survival and disease-free outcomes will be. If we look at the Kaplan-Meier survival, we see that the disease has a long protracted course, and they tend to develop distant metastasis. So what is the type of failure in them? We see that even beyond 7 to 8 years, their disease-specific survival and recurrence-free survival is overlapping. That means that their drop in survival is attributable to the distant metastasis, and they can develop them at a very long-term follow-up of say 7 to 8 years also. So always remember, we have to follow up these patients for a very long time. Foreign literature tells us to subject them to locoregional imaging with the contrast MRI every 3 to 4 months for the first 2 years, and every 6 months subsequently, and annually thereafter. So, but not always it is possible. Based on our clinical judgment and resource availability, we have to take a call on this. And also we should subject them to a CT chest annually, because they tend to fail distally, especially in the lungs. So that is my last slide. Thank you. And any questions?
Thank you, Riddhi. I have a question from you. In the management of the minor salivary glands, can you classify based on the margins? And what will be the role of margins when we evaluate the outcome?
So
As compared to squamous cell carcinomas and as compared to major salivary gland tumors.
One is that margins are not different for minor salivary gland tumors. What is difficulty in understanding intraoperative margins is because of submucosal extension and perineural invasion. What we understand as gross macroscopic margins might not be seen microscopically. Experience at reading radiology is very important for intraoperative assessment of margins in these cases. And we do know that close or positive margins have worse outcomes in terms of local control rates.
Okay, so I think remaining parts we can definitely discuss during the case presentations. And if anybody has any questions, they can put it up in the chat box. So we can take it up later, and I will request Riddhi, you also please join us for the case discussion. So Nana, you can please invite all the others.
Thank you, ma'am. That was a very good talk, explaining everything, comprehensive management of minor salivary glands, and also reading scans with normal anatomy to perineural invasion and all. So now we'll move on to the case presentation. I would like to invite today's panel of examiners. Dr. Sarvani Ghosh Laskar. She is a professor in the Department of Radiation Oncology. Hello, ma'am, from TMH Mumbai. And our next examiner is Dr. Arvind Krishnamurthy. He is a professor in surgical oncology from Cancer Institute, Adyar. Welcome, sir. And Dr. Deepa Nair, she is a professor in head and neck surgical oncology from TMH Mumbai. Welcome, ma'am. And today's case presentation will be done by Dr. Labdi Nirmal. She is a MCH resident from Tata Memorial Center, Mumbai, and she'll be presenting a case on minor salivary gland malignancy. You can start.
Yes, good evening. Good evening, my panelists. So I'm presenting the case of a 47-year-old female. She's a resident of Bangladesh, a homemaker, who presented to our OPD with chief complaints of pain while swallowing since 6 months. Patient was asymptomatic 6 months back when she started developing pain while swallowing, which was insidious in onset. It was dull aching, it was non-radiating, and it was relieved temporarily with medications. It was associated with history of foreign body sensation in the throat. There was no history of voice change, no history of any breathing difficulty, no history of any cough while swallowing. There was no history of ear pain, no history of fever, weight loss, or night sweats, no history of reduced mouth opening, no history of oral bleed, no history of any neck swelling, no history of any other ulcer or mass anywhere in the oral cavity. There was no history of any breathing difficulty, cough, blood-stained sputum, bone pain, or chest pain. She denies addictions. The patient had consulted a local ENT surgeon for the same complaints, where she underwent a biopsy from the right side base of tongue. The outside biopsy report, she presented with the outside biopsy report, which was suggestive of a low-grade adenocarcinoma. There was no significant family history. She had history of tuberculous axillary lymphadenitis, for which she was on AKT since 4 months. There was no other history of any comorbidities, any surgery, or any allergies. The patient was postmenopausal. Sleep, appetite, bowel, bladder habits were normal. So, to summarize from the history, my patient is a 47-year-old female who presented to our OPD with chief complaints of pain while swallowing since 6 months, with a possible growth in the right base of tongue with the outside biopsy suggestive of low-grade adenocarcinoma.
Lovely, Deepa here.
Yes, ma'am.
If you didn't have this biopsy, what would make you think of a minor salivary gland lesion?
Ma'am, the history that it's been long standing, 6 months history. There is, and it is only associated. She gave complaint of pain while swallowing. So definitely, and there is no history of change in voice. So it is a slowly growing tumor with no radiating pain, no history of voice change, and with foreign body sensation in the throat and pain while swallowing. So that would point towards there is no history of any neck swelling also with a 6 month history. So that would point to a salivary gland malignancy, minor salivary gland tumor.
Okay. So basically, the duration, the slow progression, and different sites in the oral cavity. These are the things which you would look for.
Yes, ma'am. Ma'am, can I continue with the examination?
Yeah, go ahead.
Okay. So coming to the general examination, my patient was conscious, cooperative, well-oriented, averagely built and nourished, with an ECOG performance status of 0. Her vitals were normal. She was afebrile with a pulse of 86 beats per minute, and BP was normal. No pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy were seen. Coming to the local examination, on inspection, the mouth opening was adequate with interincisor distance of 4.5 centimeters. She was dentate with good orodental hygiene. Tongue movements were normal. Oral cavity examination was normal. The lip, buccal mucosa, upper lower gingiva, teeth, floor of mouth, tongue palate examination was normal. Coming to the oropharyngeal exam, on Hopkins examination, there was approximately 1.5 by 1 centimeter ulcerative growth epicentered over the right base of tongue, reaching the tonsillolingual sulcus. It was away from the midline. It was away from the circumvallate papillae as well. The anterior tongue, tonsil, and vallecula were free. Bilateral lingual tonsillar hypertrophy was also seen, and bilateral vocal cords were mobile, normal. Bilateral piriform fossa were clear and normal. The inspectory findings were confirmed on palpation. There were no loose teeth, oral cavity, no lesion was seen or palpated. Oropharynx, there was induration palpable over the right base of tongue, limited to the growth. It was non-tender and did not bleed on touch. The tonsillolingual sulcus was free. The rest of the base of tongue was supple. On neck examination, there were no visible swelling, scars, or sinuses. The skin was normal. On palpation, there were no palpable nodes. The overlying skin was normal. Trachea was central and carotid pulsations were felt. Systemic examination was within normal limits. To summarize, my patient is a 47-year-old female on AKT with a non-healing ulcer over the right base of tongue, most likely a malignant neoplasm of the right base of tongue, likely a low-grade adenocarcinoma, clinically T1N0.
So, Labdi, I just want to ask you now, since you've said this is on examination, also you kind of continue to say that this is a low-grade adenocarcinoma. Is this because of the histopathology report that you already have?
Ma'am, just likely, yes, ma'am, just from the histopathology report that she presented with.
Now, again, if I may repeat Deepa's question, supposing this was not an ulcer and
Yes.
it was largely a submucosal growth, would that have gone for the diagnosis of a minor salivary gland tumor, or would it have been against the diagnosis of a minor salivary gland tumor?
It would have been ma'am, for the diagnosis of a minor salivary
So,
gland.
it's often on examination, it's also the appearance of the tumor and the feel, because most often, as you rightly said, in history, they would be slow growing tumors, but on examination, they are mostly submucosal growths that have been growing over a period of time. Now, in this case, this patient has an ulcer, but then it may very well have been a submucosal growth restricted to the base of tongue. What is the other thing about these? And this patient, though she had a large growth, was there ankyloglossia or fixity of the tongue?
No, ma'am, tongue movements were normal.
So that's another thing about being a low-grade tumor. You can't say whether it would be an adenocarcinoma or something else, because if I'm not mistaken, this was a mucoepidermoid carcinoma finally, right? Now, any which ways, so the point is that, considering that this patient actually, so the other thing is that no nodes, no ankyloglossia, and it's been growing over a period of time. And because of the mass effect itself, she is having symptoms, right?
Yes, ma'am.
Yeah, okay, fine. That's all from me. I kind of agree with Dr. Knappa's comment on the chat that maybe, you should not have access to the histopathology till you finish, because then that kind of gives you a bias about what could be the possible etiology of this particular location of the tumor. I kind of agree with Dr. Krishnappa. Okay, anyway, now let's go on. I think, is it all right, Deepa and Arvind, if she can go on?
Yeah.
Yeah, fine. So what did you do next for this patient?
Ma'am, we uh, uh, the patient underwent cross-sectional imaging. We did a contrast-enhanced MRI for the patient for the head and neck region, and we also did a PET scan for the patient.
Why did you do a PET scan on this patient?
Ma'am, we had reviewed the slides for histopathology. So it came out to be a polymorphous adenocarcinoma. Ma'am, there is a chance of these tumors, ma'am, minor salivary gland tumors, especially high-grade tumors, have a risk of distant metastasis to the lung, the bone, most likely the lung, the bone, the liver. So, ma'am, we do
1 minute.
have
Let's stop you here. You yourself had said that this is a PGLA. If it is a PGLA, what is the commonest grade of a PGLA?
Ma'am,
Are
it
they
is a
high-grade tumors or low-grade tumors?
Ma'am, most commonly they are low-grade tumors, but there
Yeah,
are
so then
15 to
no,
20.
1 minute. So that is why you have to justify doing a PET CT in a patient like this if you're saying it's a low, if it is your review called it a PGLA, and your first thing when you were presenting the history as well as the examination, you said that the histopathology report was of a low-grade adenocarcinoma. So that's why the question of a PET CT scan. So now, when will you do a PET CT scan in something which you suspect to be a thing, what you call a high grade, a salivary gland tumor? When would you do a PET CT scan?
Ma'am, I would like to do a PET CT scan when it is it's a higher stage tumor, like T stage it is a T3, T4 tumor with the N plus neck or multiple level nodes or lower level nodes, and high grade histology like high grade mucoepidermoid carcinoma, adenoid cystic carcinoma, and salivary duct carcinoma. In these patients, ma'am, I would like to do a PET scan to evaluate for distant metastasis.
Okay. So what would be the imaging of choice you said? So
Ma'am,
what
a
would you
contrast
did a PET
enhanced
CT,
MRI.
but would you do a PET, forget the PET CT for the time being. What would be your first radiological evaluation that you do in a patient like this?
A contrast enhanced magnetic resonance imaging, ma'am, of the head and neck.
Yeah, okay. And then what would you, what was the, Arvind and Deepa, please.
Yeah,
So you,
so Lavdi, suppose this was not in the base tongue, but it was a palatal lesion. Would you still do a MR as the first investigation of choice?
Ma'am, for minor salivary gland tumors with a submucosal growth, the palatal lesion also, I would like to do an MRI because it would have a it would be better to evaluate for perineural invasion and soft tissue extension.
Which pathology is associated with perineural spread? Are all minor salivary glands pathologies associated with
No, ma'am.
PNS?
Minor salivary gland, most common pathology is adenoid cystic carcinoma. That is associated with perineural spread. Even adenocarcinoma, to some extent, is associated with perineural invasion, perineural spread. And since hard palate is the most common site for minor salivary gland, and 70% of the tumors are adenoid cystic carcinoma, I would like to do an MRI to assess for perineural spread.
So on the histopathology, would you like to do anything other than knowing what kind of histology it is?
Ma'am, I would like to do IHCs and molecular testing as well.
So what IHC and what molecular testing will you do on these on the biopsy of these minor salivary gland tumors? I think Dr. Reddy showed a very good slide in the end.
Yes, ma'am. So for IHCs, P40, P63, then KI67 for mucoepidermal carcinoma, then for S100, SX, SOX, S100 and SOX10 for adenoid cystic carcinoma. Then
What else do you do for these patients? So because the markers that you talked about right now, P63, P40, KI6, P63, P40. What are the
cytokeratins also,
markers
ma'am.
for? Yeah,
Cytokeratins
what
also.
cytokeratin? Right. So that is
Cytokeratin,
essentially
yes.
epithelial markers.
Yes,
Then
ma'am.
KI67 for what?
Ma'am, for mucoepidermoid carcinoma, KI67 less than 10% is suggesting
KI67
favorable.
is essentially a marker of what?
Ma'am, cellular differentiation.
Yeah, okay, proliferation. Okay, then what other markers will you do?
The cytokeratins, then
Do you do any androgen markers? Do you do
yes, ma'am.
any
Androgen, yes,
all
ma'am.
those things you
Androgen
have to do?
receptors, HER2, androgen receptor markers, HER2 receptor marker. In
Okay.
especially when I'm suspecting salivary duct carcinoma.
Okay. Is there any other way that we classify these salivary, salivary gland cancers, minor or major?
Uh,
Do we have tumors that have high grade histologies?
yes, ma'am. So
Because if you
mucoepidermoid,
remember, Riddhi did touch upon touch upon the thing about when you're going to do elective nodal radiation, treatment versus not doing elective nodal treatment. So she talked about high grade, high stage.
yes, ma'am.
And what is the other parameter that decides your elective nodal treatment?
So
High
high
grade,
grade,
high
high
stage,
stage,
and
location of the tumor, ma'am. So
yeah,
laryngeal,
correct. Okay, fine.
nasopharyngeal primaries, nasal, sinonasal malignancies would not have very low propensity for lymph node metastasis, so they would not require
Okay,
dressing the neck.
okay. Yeah, Deepa.
Uh,
Sorry.
So, Lavdi, what would be your next step? So, you've done a biopsy, you've done radiology. So, then what will you assess for? What is the mainstay or what would be your next step? Arvind, are you there?
I don't think Arvind is
He's
there.
traveling, he just left, he'll join back again.
Okay. Then, Deepa, please go ahead.
Yeah, so I was asking what are the things which will make you decide that the patient is operable versus not operable in this? Or all cases are operable?
No, ma'am. All cases are not operable. So the TNM staging T4B tumors are not operable, ma'am, where there is gross
Do
extension.
you follow conventional TNM staging for these cases?
Ma'am, as per the new AJCC 9, we follow for even for minor salivary glands the TNM staging for salivary gland malignancies.
So can you reiterate what is the TNM staging for salivary gland malignancies?
Yes, ma'am. T1 is tumors less than equal to 2 centimeter. T2 is 2 to 4 centimeters. T3 is T1 and T2 are both without any extra parenchymal extension. T3 is tumors which are more than 4 centimeters or with tumors with extra parenchymal extension, but without any only with mucosal or surrounding soft tissue invasion and without any structural involvement. That is T3. T4 is divided into T4A and T4B, where T4A is tumors with extraparenchymal invasion into the surrounding structures, like involvement of the named nerves, then involvement of skin, involvement of bone, cartilage, involvement of the larynx, esophagus. Constitutes the T4A, and T4B are tumors which encase the common carotid artery or with skull base invasion, except for nasopharyngeal cancers, tumors with skull base invasion or with mm, encasing the common carotid. Yes, ma'am.
Okay, so then what are you planning for this patient?
For this patient, ma'am, since clinico-radiologically it's a T1 lesion, and the mainstay of treatment for salivary gland malignancies is surgery, I would like to do an EUA to assess for feasibility of transoral resection in this case.
What are the factors you will do, or what are the examination findings which will say that this is suitable, and what will make it unsuitable for a transoral excision?
Ma'am, involvement of the tumor arising, if there is extension into the anterior tongue, then if there's extensive extension into the lateral pharyngeal wall, lateral oropharyngeal wall, then involvement of the epiglottis or the supraglottis, then extension involvement lesions that are crossing midline, deeply infiltrative tumors involving the extrinsic muscles of the tongue, especially the genioglossus. These would be my exclusion criteria for transoral resection.
If the patient has a tumor which is extending from the waist tongue to the epiglottis, you will not offer surgery for the patient.
Ma'am, I would offer surgery, but if I would want to assess for the depth of the tumor and see whether it is amenable for a transoral resection or otherwise offer an open approach.
So this case of waist tongue, when
Hello?
what open approaches do you offer for the patient?
Hello? Your voice broke in between. We'll have to. We lost you. Sir.
Yeah, ask what are the open approaches you can
Hello?
What are the open approaches that we can use for those tumors? That's what she wanted to ask.
Ma'am, I can offer a transcervical approach, paramedian mandibulotomy approach, then lateral pharyngotomy approach. or a combined approach, ma'am, trancervical and transoral.
Which one would you prefer and why? You've not got the imaging of this patient. Do you have it?
I do have it, ma'am. I do have the imaging, ma'am. So, ma'am, for
Can you
this
please talk
case,
us through the imaging?
yes, ma'am. So, these are axial contrast enhanced imaging, T2 weighted images of the neck, starting from craniocaudally. As we go down, we can see the palate and the hard palate and the gingiva coming into picture. We can see the mandibular ramus. We can see the pterygoid muscles. As we go further, we can also see the parotid and the masseter muscle laterally. As we go further down, we can see the tongue, base of tongue and tonsil coming into picture. As we go further down, we can see a polypoidal, well-defined growth arising from the right side base of tongue, which is reaching the tonsillolingual sulcus. Anteriorly, we can see the mandible. And as we go further down, we can see the hyoid now coming into picture. So from the imaging, it is a well-defined polypoidal growth. It is limited to the right side base of tongue.
What are the factors would you consider when you are applying treatment for this patient?
Ma'am, the factors to consider would be the T stage, the involvement, the location of the tumor. In this case, it's the base of tongue. So I would like to see whether it is extending into the lateral oropharyngeal wall, whether it is extending, it is involving the deep or the extrinsic muscles of the tongue, especially the genioglossus muscle. And then I would like to see the involvement, whether it is involving the vallecula, the epiglottis, and distance from the hyoid.
What about feasibility of suspending and getting a proper exposure?
Yes, ma'am. Yes, ma'am. So I would
So
like to
I think
assess.
maybe that, yeah. So if you are planning to do a transoral resection, first thing you would be talking about is whether you are able to get adequate exposure of the lesion. Arvind, would you want to ask some questions?
No, I think I sort of tried to join, but but I guess I was a little late. But very quickly, this is was a biopsy done for this patient?
Yes, so the biopsy was done for this patient, and it was a polymorphous adenocarcinoma.
Right, right. So the again, I'm not sure if it was discussed earlier that would you sort of like to do a biopsy, or when is the threshold to do an excision biopsy? Like some of these lesions are so very proliferative, some juicy. So when do you want to sort of do a excision biopsy rather than sort of a shorter than an excision biopsy, an incisional or puncture?
So I would like to do an incisional biopsy only. Excisional biopsy uh, would, if there is an obvious growth, an excisional biopsy.
So what is your threshold? Any size threshold? Like for example, this is around barely 2 centimeters, right?
Yes.
So when would you sort of contemplate on doing an excision biopsy?
Um,
So, Labdhi, why you want to do a biopsy and why not an excision biopsy is what
Yeah.
Dr. Arvind is asking.
so, ma'am, an incision, I wouldn't want to do an excisional biopsy because I would not be certain of the margins of resection. And to go ahead for a second, to go in for a second stage surgery later would mean very unguided and would entail more extensive resection, which would compromise the functionality and outcomes as well.
What are the other mimics in this area which you can have?
So,
Any other pathologies?
yes, ma'am. So most common in base tongue is squamous cell carcinoma. I can also have lymphomas, then salivary gland pathologies, minor salivary gland tumors.
There is a
So
concept
exactly,
called
this is
extracapsular dissection, right? For, say, described for parotid tumors, pleomorphic adenomas specifically.
Yes, sir.
So would you sort of consider anything of that sort here, or
Pleomorphic adenomas are benign tumors and they have a well-defined capsule. For minor salivary gland tumors, they don't. They are usually carcinomas, malignant tumors, and even if it's a pleomorphic adenoma arising in a minor salivary gland, it does not have a very well-defined capsule. So extracapsular resection would not have a role in.
so I guess your thing is the predilection for malignancies is probably very high in minor
Yes,
salivary gland tumors. I guess
yes,
that would be one of the reasons why you would sort of, despite it sort of, pretty benign looking, also you would sort of, go for incisional biopsy. Yeah.
yes, sir.
what would be your margins of resection?
Ma'am, my margins would be for salivary gland pathologies, more than 5 mm margins. I would aim for more than 5 mm margins.
Is that correct for
Yes, sir.
salivary gland tumors? And especially now when you have a minor salivary gland tumor located at the base of tongue? Or are you just extrapolating from squamous cancers?
Any evidence to substantiate your statement of 5 mm, or would a lesser margin also suffice?
So for minor salivary gland tumors, lesser margins also suffice. We need negative margins, but
Right.
sometimes there are chances of having there could be some perineural invasion, or there are chances of having satellite lesions, or so for clear margin.
Satellite you would pick up in an MR.
I think you should stop at that and say that you should have negative margin.
Negative.
You can aim for a wider margin, but then typically because of the location of minor salivary gland tumors especially, you can have negative margins is what you would aim for. That extrapolation 5 millimeters is essentially from squamous carcinomas. All right.
Yes, ma'am.
Deepa, Arvind, can you please correct me? Please correct me if I'm wrong. But that's my
No, I
understanding.
agree.
No, yeah,
I was going to ask about that. That when you have these lesions, they'll be very close to the hyoid in the depth. You're not going to resect the hyoid, or you're not going to do unnecessary surgery for that 5 millimeter histological margins. Again, there is no strong evidence or no strong literature to suggest that larger margins may be better or lesser margins may be inferior in minor salivary gland neoplasms. Again, these are very limited series and all are retrospective. So most of them suggest that histologically free margins is what you're achieving.
but in this case, it would be easier for you. Like, you could go the 5 mm way, because I guess, it is very easy to. So my thing is, don't aim for that 1 mm or something of that sort, which some people say. Maybe just go a little generous, but that is intraoperatively. But I guess Any negative margin, they say, is reasonably good enough.
So, Lavdi, in this
So if-
patient, are you going to do a neck dissection or not do a neck dissection? Or how are you going to address the neck in this patient?
Ma'am, this is an N0 neck, but this patient, the histology is a polymorphous adenocarcinoma. So for polymorphous adenocarcinomas, around 15% of the cases in retrospective analysis have found to have N plus later on. So, ma'am, I would like to address the neck. And since it's the base of tongue, I would like to do a comprehensive. Initially, I would like to do a level 2A sampling and subject it to a frozen section. If it is a positive, I would like to do a comprehensive neck dissection. And if negative, there is also a school of thought that for T1 N0 and low grade salivary gland malignancies, we can observe the neck if level 2 sampling is negative on frozen section.
Is there a formal grading for polymorphous adenocarcinomas?
So for polymorphous adenocarcinoma,
No, is there something called polymorphous low-grade adenocarcinoma?
so it has been removed from the 2022 classification.
Okay, correct. Yep. I just wanted to check whether you were aware of that. Yep. It was earlier, they used to sort of, have this thing called PLGA. And I think if you see the literature, there are a lot of reports on polymorphous low grade, but with the amended WHO 2022 classifications, a lot of changes have happened, including this. Right. Very good.
So, Labdi, I think comprehensive neck dissection, there's not much literature. Again, like you said, that the chances of nodal metastasis in some series are up to 15%, but that depends also on the size of the tumor. Uh, a reasonable strategy would be to address, especially when you plan transoral resections in these cases, would be to do levels 2 and 3. I don't think you need to do beyond that. But again, I don't have strong evidence to support my statement in the absence of node negative on the scans. Primarily because when you're going to do a transoral resection, you're also going to try and address the vasculature by clipping the facial and the lingual.
Lingual, yes, ma'am.
Yeah. If it was an N plus neck, then
Yeah.
what would you be the extent of your nodal dissection?
Sir, I would, if it was an N plus neck, then I would do since this is a base tongue tumor and it is well lateralized, I would do a level 2 to 5 neck dissection, so comprehensive neck dissection.
Right. I think surprisingly, that is what the evidence says, Maybe in squamous cancers, there is evidence to do lesser than a comprehensive neck dissection in plus cases, but somehow in minor salivary, they say up to 40%, I guess, in some older series, though. So I guess, 2 to 5 would be a reasonable answer to give. Deepa, is okay, or any other thoughts from your end for an N plus?
No, I agree. Again, incidence is much lower and we really don't know. And, we don't have prospective data to really suggest. So it's on a case-to-case basis, I guess. So, Labdi, you've operated on what grounds will you offer any adjuvant treatment for these patients?
So, ma'am, I would offer adjuvant treatment in cases where my margins are positive, where I have higher T stage, T3, T4 tumors, or N plus neck, in patients with high grade tumors, aggressive histology, I would like to offer adjuvant radiotherapy.
What about the histology of an adenoid cystic carcinoma?
Yes, ma'am. Adenoid cystic carcinoma, I would want to offer a
So all
high-grade mucoepidermoid.
So all adenoid cystic carcinomas, all tumors that are more than 2 centimeter in size. So that's how you'll have to say indication for adjuvant radiotherapy and minor salivary gland and the other things, of course, you said, and N plus tumors, right?
Yes,
And
ma'am.
high grade. Yeah, okay. What is the role of chemotherapy, concurrent chemoradiotherapy, or concurrent concurrent chemoradiotherapy in cases of salivary gland tumor?
Ma'am, there is no established role of concurrent chemoradiotherapy, although there's an ongoing trial that is
Is it?
evaluating the role. Uh,
Which is that trial?
I think it's
The RTOG?
RTOG 1008.
Yeah.
Right.
We really don't know what's happening on that trial because we really don't know its accrual. But can you quote any studies which have evaluated the role of adjuvant chemoradiotherapy? And some are negative, definitely. And if at all, if you have to give concurrent CT, which particular histologies would benefit from adjuvant concurrent chemoradiotherapy? You're correct in saying that for the general rule is that we do not consider giving concurrent chemotherapy. Rather, it's been found to be detrimental. Can you quote studies for that? And can you quote studies which favor addition of concurrent chemotherapy and for which histologies?
Ma'am, I'm not aware of the studies.
The NCDB analysis, which says that there is definitely no role. Plus, one of the first studies that was done was the same one uh, by Tankatwan, that same girl lady. So again, there is no role, but of course it can be given, and there may be a role for giving concurrent chemotherapy, especially in salivary duct carcinomas, and there is a small series for adenoid cystic carcinomas. But overall, if you say for salivary cancers, there is no role of adding adjuvant concurrent chemoradiotherapy, but yes, for radiotherapy. When will you do elective nodal irradiation? Supposing you've operated, you've done neck node sampling. Then when do you do elective nodal irradiation?
Ma'am, again for high-grade histologies, and if I have done a sampling and the frozen is negative, but my final histopathology report says that it is positive, or an N plus neck, ma'am, I would do elective
And high grade and high stage.
high-grade, high-stage tumors.
And of course, depending on the location. So any site that has a higher propensity for lymphatic metastasis, you would do elective nodal irradiation. Yeah, and you know the modalities of radiotherapy that have been used? I think we did mention.
IMRT only, ma'am. IMRT,
So today there is evidence
which
to suggest
guided also. Yes,
particle
ma'am.
therapy also. So
Yes.
particle therapy essentially either protons or you have carbon ion therapy. Neutron therapy, though it used to be discussed, has actually, though it has been used, has generally gone out of use simply because the toxicity of using neutron therapy, the necrosis associated with neutron therapy was much higher. But for unresectable salivary gland cancers, there is evidence to suggest the use of particle beam radiotherapy. Do you know anything about targeted therapies in the use of salivary gland carcinomas? And what are the indications for the use of targeted therapies?
Yes, ma'am. So, targeted therapies, so there's a Japanese trial where they studied trastuzumab with docetaxel, targeted therapy in recurrent salivary duct carcinomas, recurrent and metastatic, in the recurrent and metastatic setting. And they found that there was a 70% response rate. Also, NTRK inhibitors like larotrectinib have been studied, where they have seen a 75% response rate. Also, salivary duct carcinomas being positive in androgen and HER2 receptors. So, leuprolin, then bicalutamide are androgen receptor blockers that have been studied in salivary duct carcinomas uh, that are positive for androgen receptors and HER2 receptors, trastuzumab. There's also the MyFismo trial, which in which they have used a vaccination with PD-1 inhibitor. They have used the MYB, the TET MYB vaccine with in adenoid cystic carcinoma with the PD-1 inhibitor. And that has they have seen a good objective response rate of approximately 20%.
Can you use some of these agents in the adjuvant setting? I know the evidence is limited, but from all the agents, couple of agents,
So
some
the
people may use it.
androgen
Yeah,
receptors can be used in the adjuvant setting.
androgen and HER2.
And
HER2.
her,
Yes,
that
ma'am.
means trastuzumab, the breast-like regimes, yeah?
Yes,
Yeah.
ma'am.
That's all from me. Thank you, lovely.
Thank you, ma'am.
What will you do on follow-up for these patients?
So, follow-up imaging, ma'am, I would, after completion of adjuvant treatment, the follow-up would be at 3 months, I would like to do a PET scan in these patients. Because high grade, if the depending on the histology, again, high grade, high stage tumors with N plus neck, there is a propensity for distant metastasis even after 5 years and 10 years of treatment. So, a baseline PET after response after treatment would be.
But would you do that for all histologies? This 5-year, 10-year is for a specific
Yes,
histology,
ma'am.
no?
For high-grade mucoepidermoid carcinomas, adenoid cystic carcinomas.
Yeah, so that is why you would do a CT perhaps in the long term. But then for this kind of a, you said this was a low-grade adenosia. I may perhaps agree with you that at the first 3-month follow-up, I may do a MRI, but not a PET-CT in this patient. That would be my follow-up strategy. And there, of course, I would do with clinical examination. Deepa, Arvind?
So I tend to image more frequently with MRI. 6 monthly, I would keep the patients on MRI for the first 2 years, because again, these are generally tumors which are not which are going to be submucosal, not like a squamous carcinoma which you see in the mucosa. So I'd rather pick them up with the help of an imaging. So my policy to do MRIs at 6 monthly intervals. Again, for a major salivary gland tumor like a salivary duct carcinoma, where you know that the incidence of distant metastasis is high, maybe a PET CT at follow-up, yearly follow-up of something may make sense. But for adenocarcinomas, I don't do PET CTs very frequently.
Sabdi, I have a question from you. Asim here.
Yes, sir.
So suppose you have a patient with metastatic disease at presentation and a patient with metastatic disease of minor salivary gland tumors
Yes.
in follow-up. How
Yes.
will your approach towards the patient?
So if the primary is resectable, I would still go ahead with resection of the primary and address the neck and give the patient adjuvant treatment if indicated. Even with distant metastasis, most of these salivary gland tumors have a good 5-10 year overall survival, upwards of 50 to 70%. So I would want to address the primary and
And how would you be planning? Suppose at presentation you have a metastatic disease. So how are you planning to manage the metastatic disease that is a resectable resectable tumor.
Sir, if any targeted therapy options are available, then I would like to give targeted therapy for the patient. If it is, I would like to explore the option of SBRT if it is just and if it is oligometastatic disease to the lung, and if it is resectable, then I would like to go ahead for resection. And if it is um,
Any
or
other option of you would like to
S
add? There is SBRT, there is surgery,
SBRT also surgery, then targeted therapy, sir, if or
and
I would just like to observe.
or RFA. Would you like to? When would you consider an RFA for such lesions for a metastatic disease based on your location?
RFA.
Radio frequency ablations.
Yes, sir. I'll have to read about it, sir.
Well, maybe discuss with your intervention radiologist as well. So we do consider for patients even in lung or even in liver lesions, if there are oligometastatic or 1 or 2 lesions, we consider for radiofrequency ablation as well. That is also one of the options. And the targeted therapy, surgery and SBRT definitely are the primary options if that is possible.
So I would like to disagree with Labdi on the fact that all minor salivary gland lesions who are metastatic, I would still offer surgery locally. It again is histology driven. So if there's a higher tumor like a salivary duct carcinoma, which is poor prognosis, and the patient is metastatic at presentation, I would be offering targeted therapy directly without offering local therapy for these patients because again, survival is poorer in these cases. But
Yes.
something like an adenoid cystic carcinoma or maybe a mucoepidermoid, you would still think of offering local therapy. So it again is very histology dependent.
Yes, ma'am.
And I would like to know what Arvind and Sarbani think.
I agree with Deepa. I would actually offer this option of a metastatic carcinoma being treated aggressively only if the histology is an adenoid cystic carcinoma and not other histologies, because these are slow growing tumors and the patient may really not be metastatic. And also you have to today, at least when you speak about these tumors, you have to talk about whether they're oligometastatic or polymetastatic. So this is, I would definitely not treat a patient with a high grade tumor aggressively, but with an adenoid cystic carcinoma, I may still consider treating the patient aggressively for locoregional therapy. I agree with you, Deepa. Sorry, Asim, I have to leave now. Can I? Thank you very much for the
Sure,
invitation.
ma'am. Thank you so much, ma'am, for joining.
Thank you.
Thank you, ma'am. Ma'am, even if it's a T1, T2 lesion with the
See, supporting Labdi, this is a salivary duct carcinoma. I wouldn't want to treat a metastatic salivary duct carcinoma aggressively because I know this patient is going to succumb to his or her metastatic disease soon, and it's going to spread like wildfire. But at the same
Okay.
time, if this was an adenoid cystic, I would have treated it more aggressively. Sorry, I'm leaving.
Yeah, I
Yes.
agree. The other thing is about the polymetastatic thing as well. So if it's if even it's a T1 and T2, if it's polymetastatic, you still would sort of, in a salivary duct or high grade adenos, you would give the systemic options, buy time, see how it behaves, and then take it. But yeah, in oligometastatic scenarios, then things might change essentially. But by and large, is right. I think I also agree with what Deepa and Dr. Sarbani says, that it's driven by histology and also driven by the how many metastases are there essentially. And metastatectomies and all we've done, but I think it's pretty rare essentially to
Yeah,
sort of.
so I agree. If you have multi-system metastasis, so only lung metastasis behave differently, but if the patient has lung, liver, and bone, that is completely different biology of the patient. So you need to put all of these things in perspective
Yes.
rather than just thinking about or lumping all minor salivary glands together.
Yes, ma'am.
But I think Labdhi has answered most of the questions quite well. And I think she's brought about a lot of discussion and points. So
Yeah, I
if
agree.
there are no, yeah, if there are questions from the others in the chat, maybe we can answer those, or then if with Asim's permission, we can call it a day.
I think there are no questions in the chat box. Okay, so I think we'll call it the day now. So thank you, Deepa ma'am. Thank you, Sarvani madam. Thank you, Arvind sir, for joining. Thank you, Riddhi, for the excellent presentation, and thank you, Labdi, for the wonderful case presentation. So thank you
my
all for
teacher.
joining, and we shall meet once again after 2 weeks. Thank you all.
Thank you.
Thank you.
Thank you, my teachers.